Welcome to Evidence Mastery with Dr. Masood Tusi. I am going to help you understand what bladder cancer is and how it is managed. Please note that this video is for education only and will not replace your doctor's advice. Bladder cancer can feel like a really complex topic. So our goal today is simple. We're going to unravel that complexity. We'll break it down into clear, evidence-based parts so you can really understand what's going on. All right, let's get started. So let's kick things off with a question just to set the stage. Any guesses on what the fourth most common cancer is for men in the United States? It's bladder cancer, and that's exactly why we're talking about it today. Its prevalence really shows how important it is for all of us to get a handle on this disease. Okay, so let's start at the very beginning with the fundamentals. Before we can even talk about managing bladder cancer, we've got to be crystal clear on what it actually is. All right, so what are we talking about here? At its core, bladder cancer is a disease where malignant or cancerous cells start forming in the tissues of the bladder. Now, think of the bladder like a balloon. The cancer almost always starts in the cells that make up the inner lining. We call those the urothelial cells. It makes sense, right? This is the layer that's in constant contact with urine and, well, any cancer-causing agents that might be in it. And to give you a sense of the scale here, the latest evidence from 2024 suggests we're seeing about 83,000 new cases in the U.S. every single year. So, let's be clear, this is not some rare disease. It is a major public health issue that affects a lot of people. Now, here's something really interesting that the evidence points to. There's a huge difference in who gets this disease. Just look at this. Bladder cancer is about three times more common in men than in women. The reasons for that are pretty complex, but it's an absolutely critical piece of the puzzle. So that really begs the question, right? Why? What are the things that increase someone's risk? And what different forms can this cancer take? Well, that's exactly what we're going to dive into next. Okay, let's talk risk factors. And the evidence on this is just overwhelmingly clear. The number one culprit? Smoking. It's responsible for at least half, that's 50% of all new cases. It's huge. Now, there are other big ones too. Things like long-term exposure to certain industrial chemicals, like the aromatic amines you might find in dye or rubber manufacturing. Also, the chemotherapy drug cyclophosphamide can be a factor. And even just chronic irritation of the bladder over time, say from a long-term catheter or persistent bladder stones. All right, so when a pathologist looks at these cancer cells under a microscope, what do they see? Well, it turns out one type is by far the most common. As you can see right here, over 90% of all bladder cancers are what's called transitional cell carcinoma, or urothelial carcinoma. Remember those urothelial cells we talked about, the inner lining? Yep, this is the cancer that starts right there. Now, even within this one main type, the tumors can grow in two very different ways. On one side, you see what we call a papillary tumor. Think of it like a little mushroom or a cauliflower growing outward from the bladder wall on a stalk. But then, on the other side, you have something totally different. A sessile tumor. It's flat. And this is a really, really important distinction. Why? Because these flat sessile tumors are much sneakier. They're more likely to invade deeper into the bladder wall. And that, as we'll see, changes everything. Okay, so we know the risks, we know the types, but how would you even know you have it? What are the signs? And how do doctors figure it out for sure? Let's walk through the symptoms and the diagnostic journey. The number one sign, the thing that brings most people to the doctor's office, is something called hematuria. It's just a medical term for blood in the urine. Sometimes you can see it. We call that gross hematuria. Other times it's microscopic, and you'd never know it was there without a test. But here's the key takeaway. Any unexplained blood in the urine is a red flag that absolutely has to be investigated. So once that red flag is raised, there's a pretty clear pathway to get answers. It all starts with a symptom, usually that blood in the urine. That kicks off a few things. You'll likely have a urine cytology test where we look for cancer cells in the urine. Then comes imaging, maybe a CT scan or an ultrasound to get a good look at the whole urinary system. But the gold standard, the only way to know for sure, is the final step, a cystoscopy and biopsy. That's where a urologist uses a small camera to look inside the bladder and takes a tiny tissue sample. That sample is what gives us the definitive diagnosis. All right, so let's say the biopsy comes back positive for cancer. The diagnosis is confirmed. The next question, and it's maybe the most important question of all, is how far has it gone? This is called staging. And to really get a grip on staging, you have to understand a little bit about the bladder's anatomy. The bladder isn't just a simple bag. It has layers. And the most important layer for us is the detrusor muscle. This is the thick, strong muscle wall that squeezes to empty the bladder. And when it comes to staging, everything boils down to one critical question. Has the cancer grown into this muscle layer? The answer to that one question splits bladder cancer into two completely different worlds. It's the ultimate fork in the road, and it determines everything that happens next. On one side, you have non-muscle-invasive bladder cancer. As you can see, the tumor is still just in the inner lining. On the other side, you have muscle-invasive cancer. The tumor has broken through and is now in that deep muscle wall. This single fact is the most important factor in deciding on a treatment plan. And that brings us right to our next topic, treatment. Because how we treat bladder cancer depends almost entirely on which side of that muscle-invasive line the cancer falls on. Okay, so first up, let's talk about non-muscle-invasive cancer. Here we have two main jobs: get rid of the tumor that's there and stop new ones from popping up. The first part is done with a procedure called a TUBT, where the surgeon basically shaves the tumor off the bladder lining. But that's not the end of the story. Think about it. Whatever caused that one tumor was in the urine, washing over the entire bladder lining. We call this a field effect. So to tackle that, we often use what's called intravesical therapy, putting medicine directly inside the bladder. This might be a chemotherapy like mitomycin C, or a really fascinating immunotherapy called BCG, which basically revs up your own immune system to go hunt down and destroy any remaining cancer cells. Now, for muscle-invasive cancer, the game completely changes. Because the cancer is in the muscle, it has a much higher chance of spreading to other parts of the body. So we have to be a lot more aggressive. The standard approach is often to start with chemotherapy before surgery. We call this neoadjuvant chemo. The idea is to shrink the tumor and also to mop up any cancer cells that might have already escaped. After that, the typical next step is a radical cystectomy, which is the complete removal of the bladder. Now, for some select patients, there are protocols that combine chemotherapy and radiation to try and save the bladder, but the standard is often surgery. So if the bladder is removed, you might be wondering, where does the urine go? Well, surgeons have to create a new path for it, and that's called a urinary diversion. There are two main ways to do this. One option is the ileal conduit. Here, the surgeon uses a small piece of the intestine to create a channel that leads to an opening on the abdomen, called a stoma. Urine then drains into a bag on the outside. Another, more complex option is the orthotopic neobladder. In this case, the surgeon actually builds a new bladder out of intestine on the inside and connects it to the urethra. This can allow a person to urinate in a more natural way. All right, we've covered a lot of ground. So let's wrap up by talking about what the evidence says about outcomes, the prognosis. And we'll quickly recap the most important takeaways you should remember from all this. So what can patients expect? Well, it all comes back to that one question: muscle invasive or not? For non-muscle invasive cancer, the news is generally good. As you can see, it has a nasty habit of coming back, so surveillance is key, but the long-term survival rates are high. But for muscle-invasive disease, it's a much tougher fight. The evidence points to a 5-year survival rate around 50%. That's a coin flip, and that huge difference just hammers home the point. Catching this disease early, before it gets into that muscle wall, is everything. So, if you're going to remember just a few things from today, let it be these 4 points. 1. The most common first sign is blood in the urine. Don't ignore it. 2. Smoking is the single biggest risk factor you can control. 3. The absolute most important question for treatment is whether the cancer has invaded the bladder's muscle wall. And 4. The treatment plan, whether it's local therapy or major surgery, is built entirely around the answer to that question. And this really brings us to the ongoing challenge in caring for patients with bladder cancer. Because of that field effect we talked about, the risk of recurrence is always there. The work isn't over after the first treatment. So it leaves us with a really important question for the future. How can we get better at surveillance? And what new therapies are on the horizon that can really improve the long-term journey for these patients? That's exactly where the research is headed. I hope you enjoyed this video. Please feel free to share your experience or questions in the comments. Please note that I won't answer personal questions. If you found this video helpful, don't forget to subscribe to my channel.